My name is Peter Nilsson from the Lund University in Sweden. We are running late and I will keep strictly on time because respect for you and for other speakers. So my task today is to address hypertension, diabetes, timing, targets and treatment challenges. I will review some of the newer findings, only new slides. And I promise you can have all my slides afterwards if you would like to use them yourself. We know that hypertension and diabetes are two brothers in crime because they act synergistically to increase the risk. Could you please come in and close the door? Of course, one way to survive diabetes is to have a normal blood pressure. This was addressed already many years ago by Sir Edwin Gale, former editor of Diabetologia, addressing survival in type 1 diabetes that I will come back to tomorrow in my second lecture. First, we start with the timing. When shall the patient take antihypertensive drugs, in the morning or in the evening? This has been a hot topic for some years. A Spanish study could show that it's the nighttime blood pressure levels that are most important for prediction of future cardiovascular events. More important than the daytime blood pressure based on ambulatory blood pressure recordings. This led to the idea that bedtime intake of antihypertensive drugs should be more beneficial than in the morning. A few years ago, this Spanish professor Hermida published fantastic results to show that the risk for future events, this risk was much lower when treatment was provided at bedtime compared to morning intake, also including patients with diabetes. However, it was too good to be true because the hazard ratios were so impressive for all endpoints. So some people got suspicious and started to criticize these findings. One of my Swedish colleagues, Dr. Mattias Brunström from the Umeå University in Sweden, he summarized the critical arguments against the HYDIA project results from Spain in a paper in Hypertension. I will not go into all the details, but there were several aspects of criticism towards this study, too good to be true. And then came a much larger study from the UK, the TIME study. Almost 20,000 patients were randomized to morning intake or bedtime intake of all their antihypertensive drugs. And as can be seen here, there was a non-significant difference. In essence, it doesn't matter very much if you take antihypertensive drugs in the morning or at bedtime, according to this randomized large-scale study. Also, the adverse events were rather comparable. However, there was no inclusion of ambulatory blood pressure recordings, and I would suggest that it's fully possible that a subgroup with sleep apnea could benefit more from bedtime intake because, you know, they have the non-dipping phenomenon. So I take it for most likely that within this large-scale TIME study, there might be subgroups who benefit more by bedtime intake. But in the end, the patient is free to make his or her own choice when to take the medication. But for most people, I guess it's more convenient to take it at breakfast in the morning because it's more easy to remember. But if there is a non-dipping pattern, I think it makes sense to recommend bedtime intake if you cannot treat the sleep apnea phenomenon in other ways with weight loss or bariatric surgery or CPAP treatment. So let's talk now about blood pressure targets in diabetes. This has been widely discussed. A few years ago, you remember there was a debate on the J-shaped curve, whether the risk increased with too low achieved blood pressure levels. Because many patients with diabetes have silent myocardial ischemia, you know. They have no obvious signs of angina, and therefore it could be detrimental, it could be dangerous, in fact, according to some suggestions, to lower it too much. This is a slide from the National Diabetes Register in Sweden, my country, where we register data from all diabetes patients, not only treated at the hospitals, but also in primary health care. Like 90-95% of all diabetes patients in Sweden are included in this national register. As can be seen here, the yellow graph shows that approximately 58% of all patients undergoing treatment for hypertension in diabetes achieve a blood pressure below 140/85. This means that 45% do still not achieve this goal. So in my opinion, and I bring it to you, the major problem is to bring all the patients more or less below 140/85. The minor problem, at least in my opinion, is to bring a few patients to very excellent goals when we still have this burden, the clinical burden in the population of many patients not reaching a reasonable goal. We should also remember that sometimes it's hard to achieve effective blood pressure goals for blood pressure lowering, just because arterial stiffness, insulin resistance, and other detrimental factors that will make the treatment less effective. So despite the patient telling us that he or she is taking the tablets every day, that there might still be some resistance to the drug effect, a clinical problem. And furthermore, some patients will experience side effects like orthostatic reactions that will also stop more ambitious goals sometimes. Let's take a look at the guidelines. In 2018, we had joint guidelines from the European Society of Cardiology, European Society of Hypertension, but in 2023, there was only a set of ESH guidelines because these two organizations split up, a divorce, and I tell more about that in a minute. But way back in 2018, the systolic blood pressure target range for patients with diabetes was between 120 and 130 if younger patients. But in patients over and above 65 years, it was in the target range of 130 to 140. So there was a stratification according to the age of the patient and with different levels of evidence, as can be seen here. This was the view in 2018. And now in 2023, there was a divorce. And if you want to know more about it, there is a special reference addressing why. A lot of diplomatic problems, a lot of negotiations. But in the end, ESH believes they are the stronger big brother to take control of the younger brother, ESH, because there is money into this. There is funding, there is the interest of the pharmaceutical and device companies. And with things like renovascular denervation, there is money. And the ESH knows that, and that is why they want to grab hypertension for themselves. But it's a bit stupid because so many organs are affected by hypertension, not only the heart, you see. But according to the 2023 European Society of Hypertension guidelines, the blood pressure goal was to go lower than 130/80 millimeter mercury in most patients irrespective of the age of the patient. You see how problematic this can turn out to be in clinical practice when we face orthostatic problems in so many frail elderly patients. So it's like people sitting at the desk thinking about what would be the perfect world. But clinicians know more. They know that it's hard. And we should be very realistic and do our best with these patients, but not to be dogmatic. And I would like to quote Professor Giuseppe Mancia, who once told that guidelines should be educational, not prescriptive. It's not like written in stone. You should use your own clinical knowledge and try to understand what's applicable for an individual patient. Already 2023, there was a discussion on the benefits of the new anti-diabetes drugs, as has already been discussed during this conference, with different levels of evidence, of course. Let's now turn to the 2024 European Society of Cardiology guidelines for the management of elevated blood pressure and hypertension. Please notice, elevated blood pressure was something new. New kid on the block. And the Americans are very fond of that. They want to label the majority of Americans to have elevated blood pressure. Who is going to control them? Primary healthcare staff is already overburdened. This is another example of some wise guys lacking clinical skills, in my opinion. In Sweden, we have a proverb saying that the best should not be the enemy of the good. You see the point? We have to find a practical solution, a practical way that fits your everyday clinical practice. And once more, Giuseppe Mancia, guidelines should be educational, not prescriptive. Let's take a look here. In the red square, you see that they aim for 120 millimeter of mercury as a systolic blood pressure goal. Because observational studies, they tell us that the lower is the better. It's like a linear relationship. But intervention studies have been hard to find to really show the benefits. Even one of the most well-cited intervention studies, SPRINT study, has got a problem, a mystery. No stroke prevention in the intensive OB, despite blood pressure lowering to almost 120. So a lot of side effects and lack of evidence for stroke prevention in SPRINT, a puzzling fact. But this is written in the guidelines. And I can tell you, because I was a reviewer of these guidelines, that the authors, this guy with not so much clinical experience in primary healthcare, I know, he's a professor in Ireland, cardiologist. They just don't want to understand the difficult situation in clinical practice. So they wanted, in the first draft, to have a blood pressure goal of, systolic blood pressure goal of below 120. But many reviewers, including myself, we objected to that. It's unrealistic in the real world. And therefore they stayed with systolic blood pressure 120 millimeter mercury is the optimal point in this range if tolerated. A bit of a wishful thinking, in my opinion. But otherwise, they target a systolic blood pressure range for patients with diabetes, or persons with diabetes even, in the range of 120 to 129. And that is compatible with the previous recommendation of below 130. But still far from the real world. I showed you data from Sweden that 45% of the patients, almost half of them, are not below 140 over 85. Let's go to United States. 2024, American Diabetes Association Standards of Care in Diabetes. And they also want to see these blood pressure goal below 130 over 80 millimeter mercury if it can be safely attained. It's always with some precautions, if tolerated, if it can be safely attained. And we know that many elderly people with diabetes are just frail and prone to side effects like orthostatic reactions and polypharmacy. You know this. This is the treatment algorithm, and there is a transatlantic difference because in Europe, people are much more positive to start with combination therapy early on. But look here, start one agent to the left. So they are still considering that monotherapy is the logical way to start. But Europeans are more open to combination therapy already at start. And then you can increase the dosages or you can add drugs if needed. And this is a continuation of the same algorithm. Different drugs can be combined. No mentioning of beta blockers, and the European Society of Cardiology are not fond of beta blockers either. But the European Society of Hypertension still thinks that beta blockers could be useful. And of course, you know, there are different variants of beta blockers. The more modern vasodilating beta blockers are different from the old-fashioned ones. So a more open attitude towards beta blockers within the European Society of Hypertension as compared to European Society of Cardiology and the Americans. Beta blockers are not mentioned here. Now, in August, we had the 2025 new set of American Heart Association, American College of Cardiology guidelines for high blood pressure in adults. They skipped hypertension. Please notice, high blood pressure, because they want to embrace and include so many more. Of course, nobody can deny that from observational studies, there is a true linear relationship. The higher is the worse, the lower is the better. But that doesn't necessarily translate into clinical practice when you have to take into account all the logistics, all the problems, all the cost, and all the consequences of putting up very, very ambitious goals. Because most of you are hospital physicians, maybe a few of you are primary health care or family physicians, and they take the burden of the majority of these patients upon themselves. So they suffer from too ambitious goals, in my understanding. And in this set of guidelines, they also consider an encouragement to achieve a systolic blood pressure goal below 120 millimeter mercury to reduce CVD morbidity and mortality in patients with diabetes. So they take a step further compared to the Europeans that stayed at 120. They put below, because Americans love the SPRINT study and they are overwhelmingly impressed by their own SPRINT study to go low. However, everybody knows no diabetes patients were included in SPRINT, so it's fake news in a way. It's not really fair to use SPRINT data for the discussion on blood pressure goals in patients with diabetes, because no such patients were included. Let me present to you Professor Raymond Townsend. He had a paper in the October issue of Hypertension, because following the new American guidelines, they organized a pro-con debate. And this Townsend, he was more skeptical, providing some critical arguments. And you can see them here. And I recommend you to take a close look, because what we can learn very much from is not only the enthusiastic authors of guidelines, but the critical voices. This is the skeptical scientific thinking that we should encourage. To listen to critical arguments and critical voices. Not all of them perhaps are fully correct, but still we need a debate, not a dogma. We need a debate, so the critical voices are needed. Let's go for some meta-analysis. And over the years, there have been a number of such meta-analyses in this field, diabetes and combined with hypertension. In 2022, there is a very often cited meta-analysis, Lancet Diabetes Endocrinology. And the bottom line from that was that even if the relative beneficial effects of blood pressure reduction on MACE outcomes is weaker in patients with diabetes compared to no diabetes, the absolute effects are about similar. So the authors concluded that there should be no difference between patients with diabetes and without diabetes according to blood pressure goals or drugs or clinical care. Otherwise, we often think that we should do even better with the patients at higher risk, like diabetes or CKD or such things. But their argument is all patients are equal. Is it true? We should always keep a skeptical view. Because on this slide you see effects of blood pressure lowering treatment on primary and secondary outcomes by diabetes status at baseline. And please notice that for some of these outcomes, like ischemic heart disease, cardiovascular death, and all-cause death, the patients with diabetes did not benefit, but for stroke reduction, they truly benefited. And stroke is, of course, a component of major cardiovascular events. So it's the stroke prevention that benefits the diabetes patients, not the other outcomes. It's interesting to think about that. Maybe everything starts very early. And as you know, type 2 diabetes starts already 10 years before it's diagnosed. So some vascular aging processes in the arterial system starts early, and I will come back to this tomorrow. On this slide from the same meta-analysis, you see effects of blood pressure lowering treatment on primary and secondary outcomes by type 2 diabetes status at baseline and stratified for baseline blood pressure. And at the top, you see some fascinating data that, in fact, if patients have a baseline blood pressure below 140 millimeter mercury, this meta-analysis could not show benefits. Another puzzling finding. Of course, patients with diabetes and higher blood pressure benefit very much from blood pressure control and reduced blood pressure. But this is food for thought, according to their own over-positive, over-enthusiastic meta-analysis. If we scrutinize their own data, we see this problem. Now comes the most recent meta-analysis published in September this year, just a few weeks ago. And the authors, they lumped together 6 different studies, 2 from the USA and 4 from China. When you lump a lot of data together, you do not consider that study populations might be very different according to ethnicity or risk of disease. We know that in East Asia, people have a relatively high risk of stroke as compared to ischemic heart disease. But in Western countries, it's the opposite. And I guess Turkey and many other countries are like in between somehow. So they saw a lot of benefits for people randomized in these 6 studies to blood pressure goals below 120, or in a few subsets of the studies below 130 versus below 140 or 150. And you see a lot of benefits, but also increased adverse effects. But as I mentioned before Professor De Franzo came in, they lumped together US studies, 2 of them, Accord blood pressure and Sprint, with 4 Chinese studies. And this is, to me, problematic. And I will show you one of the Chinese studies in a minute. In the discussion part of the same paper, they address some important limitations of the study, and they admit that they lump a lot of data together that couldn't really be lumped together in an easy way. And patients' characteristics such as age and race ethnicity were closely aligned with target assignment across trials, introducing potential confounding. Let's go to one of the Chinese studies. The BP Road trial in China, involving more than 12,000 patients with type 2 diabetes plus high cardiovascular risk patients, randomized to below 120 or below 140, with some benefits. You see it here, published in New England Journal of Medicine, 2024. Please notice they didn't have a third arm below 130, just below 140 and below 120. And now comes the most important observation. This was completely driven by the stroke prevention. And as I told you a few minutes ago, there was no stroke prevention in Sprint, a mystery. So when you lump together a lot of studies from the US and from China, you see benefits, but they are very, very different, these study populations. So my argument is that these findings cannot be taken for granted in Western populations. So such studies have to be repeated in Western populations. And added to that is also a third arm below 130. Furthermore, adverse events, as seen here, were not significant between the 2 groups in BP Road. And I'm skeptical about this. China is not a democratic country, you know, and in an open label study like BP Road, some patients could be afraid of admitting side effects because then they will lose free medication or something else. You see the problem. So all other studies find a higher prevalence of adverse effects, and the authors admit that. But in this Chinese study, no difference in adverse events, and I think that's a problematic finding. So treatment challenges at last. We know from some studies that to treat some patients, non-diabetic patients who are obese, perhaps, with some antihypertensive drugs could even prevent onset of diabetes, or I would say postpone it. Because prevention of diabetes, I don't believe in. There is postponement. A few years, that's good enough, But normally, if people are on track to have diabetes, sooner or later it will come to them, in most cases, I believe. So using some of the more modern drugs are protective for new diabetes onset, according to observational studies. Then, of course, the new anti-diabetes drugs with some blood pressure lowering properties. You know that already, so I will be brief here. We know that the SGLT2 inhibitors, they reduce volume, increase natriuresis, and they reduce blood pressure. But there is another mystery. It's very hard to show stroke prevention in the studies with SGLT2 inhibitors. I discussed that with Professor De Fronzo, and I think we are in agreement that it's a mystery. And mysteries are good, because then we need more research. If everything was clear, we don't need the research. So I appreciate mysteries. But I bring it to you, no stroke prevention, despite blood pressure lowering. And these drugs, according to meta-analysis, are able to reduce systolic blood pressure a few millimeter, like 4 millimeter mercury, using ambulatory blood pressure monitoring. And also diastolic blood pressure, like 2 or 3 millimeter mercury. Not so much, but at least something. Liraglutide is one of the GLP-1 receptor agonists, as you know. And on this slide, I wanted to show you that they are also able to reduce ambulatory blood pressure both daytime and nighttime. What is a matter of debate is how much is the weight loss responsible for this and how much is something else added to the weight loss. However, there is also an increased heart rate. And to me, this is a marker of vasodilatation, because whenever you dilate the arteries and the capillaries, there might be a reflex, sympathetic activation, and increased heart rate. Does it matter? I'm not so sure, but it's there. It's a phenomenon showing some of the effects by these drugs. And semaglutide has been shown to reduce blood pressure a little bit, according to meta-analysis, not as much as the SGLT2 inhibitors, but a few millimeter mercury. Diastolic blood pressure was not so much reduced. And there was a similar effect using subcutaneous or oral administration of semaglutide, not a difference. So when you increase the incretin levels rather dramatically, there is a small blood pressure reduction, and they reduce stroke risk. Finerenone, is there a blood pressure reduction effect or not? People discuss that, but according to some studies, there is not much of a blood pressure lowering. So in summary, to keep on time and to respect you and leaving room for some questions, I talked about hypertension in diabetes, and that should be vigorously treated if well tolerated. Fixed combinations can be useful. And I believe that in the future we will also see polypills with different components, also lipid lowering. And the hot potato is this: which blood pressure goal? And I think bringing the majority below 140/90 is the first objective. Then, of course, we could go lower in well-motivated patients, in younger patients. Of course we should. But to go below 120 or close to 120, I put a question mark, and we have to wait for studies in Western populations before I believe it. All antihypertensive drugs can be used, often in combinations, but guidelines differ on the role of beta blockers. And finally, the new anti-diabetic drugs have blood pressure lowering properties, more so with the SGLT2 inhibitors than the GLP-1 receptor agonist. Thank you very much.